Hello, Andrew Merritt again. Continuing to talk about the ACL, like we talked about in the overview, which was kind of looked a little bit of everything. Now we're going to get more into the anatomy and mechanics of the knee. Again, this is going to be a whole talk, and we're not even going to get to the ACL tearing, but this is very important because it educates us on why it tore, what to do about the tear, and why rehab is important and how to prevent this from happening again. So let's dive in. This should be a little bit shorter, but the anatomy and the mechanics of the ACL. So we looked at this in the overview video, but the ACL, when we look at the MRI, so this is the front of the knee, this is the back of the knee, hip up towards the top, toes down towards the bottom, and the ACL crossing across the knee. Okay. Again, we talked about how the ACL tear it happens because of a shifting moment in the knee or a pivoting moment. Um, Important in this is the shape of the outer side of the knee relative to the inner side. So we're going to dive a little bit deep, bear with me. So if we look again back at the model just real fast. So the ACL is the central ligament in the knee joint here. The what it stops is the pivoting motion. Why is the outer side more unstable than the inner side is an important question. Well, first, the MCL on the inner side really hugs the bone. So, and it's a broader ligament, so it's much more inherently stable. The LCL on the other hand, you can actually see there's a space here. It's because it's connected out to the fibula. So it's further away. It's a smaller ligament. And naturally, the anatomy of the outer side of the knee means that it's going to pivot a little bit more. So if we zoom back in on the MRI, this is the same view of the MRI. Now, these are two views. This is the outer side of the knee, and this is the inner side of the knee. So inner side being the stable side. So let's look at that real fast. You can actually see the bone contour is slightly concave, and with the meniscus, which are these little black wedges, really makes a nice dish for the end of the femur. Look on the outer side of the knee. The bone and cartilage actually curve away. It's convex. This is like trying to balance two golf balls on top of each other. There's a natural tendency for this to want to slide out the back, and that's exactly what happens in the ACL. So since this is convex on convex versus convex on concave on the inner side of the knee, there is a natural tendency for the tibia to want to spit out. Think about squeezing down a watermelon seed and eventually it shoots out of your fingers. That's what happens when the ACL tears. This shoots out the front. And so why does this happen? So this happens because people get into this at-risk position, this dynamic valgus, okay? So if the knee, or if the hip, it starts at the hip, if the hip allows the femur to go inwards, okay, and the foot stays planted to the ground, what happens is the knee gets this angle. That puts a ton of pressure on the outer side of the knee. Now, if you load, just like the watermelon seeds shooting out of your fingers, if you load convex on convex, it's not inherently stable. It's going to want to go one way or the other. And in this case, the tibia goes forward. So what people feel is this bowing or this buckling of their knee, but what's actually happening is you're putting so much pressure on the convex on convex that it wants to shoot forward. So obviously this is going to happen more in pivoting and rotational sports. Marathon runners don't get this. They're running forward and back. Sprinters don't get this, okay? Is when your foot's planted and you twist, or when you're planted and your foot twists, like skiing, okay? Can start with weak core and hip, or a tight hip from a thing we call femoral acetabular impingement. If your hip doesn't want to allow motion, then that motion propagates down to the knee, and more of the rotational force that should be coming from your hip, because it's a ball and socket joint, goes down to the knee joint. Now, a lot of these players are quad dominant. First of all, being quad dominant is selective to playing high-level sports because it makes you fast. These are the young female athletes with big quads. They're fast. They're the speedy ones. But getting up to speed is on the quads. Slowing down is on the hamstrings. And the hamstrings attach, let's look at the model again real fast. The hamstrings attach to the back of the knee. So the quads funnel to the front of the knee here. The hamstrings go to the back of the knee. Actually, on this little ridge is one of them, and on the fibula here on the back of the knee. So if the hamstrings fire, it keeps the knee backwards. But we just have been talking about that this problem happens because the tibia goes forward on the outer side of the knee joint. So if your quads are pulling a ton from the front, but your hamstrings aren't resisting that motion, it's naturally going to have a tendency to want to go towards the front. So a lot of the rehab for prevention and for after surgery works on the hamstrings because they need to be firing, especially that outer hamstring, to pull the tibia backwards. And poor mechanics is really important, okay? So let's talk about this. So if you land coming down from a rebound and your knees do this, you're in a lot of trouble. You're not gonna make it through basketball probably, because this is naturally putting you in that at-risk position. Now, the knee hasn't shifted, it hasn't pivoted, so the ACL is not torn, but you're already in the position that overloads the outer side of the knee and wants it to spin out, okay? So land much more square, proper mechanics, much harder to tear an ACL. In fact, if the knees are like this, it's almost impossible. This is not how ACL injuries happen. If you land with your hips above your knees, above your ankles, the ACL is really just able to do its job quite well. The other thing is landing with your knees past your toes here. So that allows that sliding to start to happen. The tibia pushes forward, the femur is coming back because it's sliding at an angle, so that tibia wants to slide forward. If you land with your knees not past your toes, you're much more axially loaded, not a shear load, but an axial load. Much better mechanics. So these are some of the risks, or depending on how people naturally land. Now, you might have gotten through 16 years of playing basketball like this and it's fine, but you're always a little more at risk if this is how your mechanics are. The big thing that has made the news lately is just being female tear their ACL at a much higher rate than males. Lots of different reasons why. First of all, just a general smaller ACL cross section. This is just their anatomy is smaller, the ligament's smaller, the strength of the ligament is proportional to its cross-sectional width, diameter, and so they have a smaller ACL. They also can have a narrow notch. That's where the ACL, if we look here real fast in the model, that's where the ACL comes up, and this is what we call the notch, the upside down U, where the ACL goes through to reach all the way to the back here in the femur. Well, if that's narrow, if that's a V, not a U, then it takes less of a shift to act as a guillotine to actually cut that ACL. Females just generally often have wider hips. If you have wider hips, but your feet are still under you, you're naturally gonna start to get that valgus alignment, that knock-knee alignment. They're often quad dominant, especially if they're playing high-level sports. These are the ones that got selected to premier soccer, year-round soccer, because they were fast when they were young. They continue to just do year-round soccer, so their quads are getting stronger and stronger, and they're working out their quads. It's easy to work out your quads, a little bit harder to work out your hamstrings. So we start to get this imbalance as we get into our teenage years. The landing mechanics that we just talked about are important. Females do tend to naturally land with a little bit more of that knock-knee approach. Much more in the last 20 years, females playing competitive year-round sports. It's intense. They just are. Soccer is a contact sport, and we're seeing a lot of it. And then some hormonal fluctuations as you get into puberty. There are aspects of estrogen that cause some softening of the ligaments during certain times of the month that can play into the ACL tears. Again, the valgus knees, this is something that you can't, this is not how you land. So you can land producing more of that valgus or that knock-knee look, but you can also just be set up that way. So it's common to see a lot of males bow-legged. So if you draw a line down from their hip to their ankle, it goes inside their knee joint. That's bow-leggedness. If you do the same thing and you draw from the hip to their ankle, as best I can here, it goes outside the knee. Obviously more at risk because, again, your set point, you're just where you live every day, is more towards that buckling position that we talked about. Again, this is why knowing the mechanics of get the ACL, to understand your ACL injury is important, because now you know why that's a bad a bad situation. Now, of course, a lot of people are just neutral, but these are the factors that we have to look at as the whole picture of trying to treat the ACL effectively. This is what valgus looks like. We can sometimes do x-rays to quantify how far outside this line goes. This person is valgus. You can see the wide space between their ankles and their narrow space between their knees. And again, this is setting them up. They're already 50% of the way to this risky position. Much more risk of lots of injuries actually in the knee. We'll talk about it in the meniscus and everything too. More pressure on the outer meniscus, but also ACL tears as relevant to this conversation. Now this is getting into the weeds a little, so bear with me if you want to learn more. So tibial slope, okay? So when we look at the side view of the knee, the tibia is the shin bone, okay? And how much angle back the plateau is, where the actual joint comes together, is very important. So this is relatively normal. It's always slightly back. So here would be 90 degrees. So this is 9 degrees of a posterior slope. This is normal. Here would be a much higher. Okay, so 19 degrees. And you can see this person already had an ACL tear, and they're seaming back because it retore. And part of the reason is because of this slope. You can imagine, back to the watermelon seed, we're now wanting to spit this side out more. Okay, so this wants to spit forward or slide back, whichever way you want to think about it, because it's at a higher angle. So this is kind of, again, like the landing with your toes, your knees in front of your toes. It's creating more of that shear force instead of an axial load force. So in these situations, we'll actually go and cut out some bone and change the person's slope. This is getting a little bit more detailed, but these are the factors you need to be looking at. Your surgeon needs to be looking at to evaluate how best to treat the whole picture here. So those are the general risk factors of the ACL, or at least the big ones that we're looking at. Obviously, multiple injuries, re-tears, other ligament injuries, meniscus plays into this. But when we see just a first-time ACL tear, what we're looking at is a collection of all of these factors, because what an ACL reconstruction for you might not be an ACL reconstruction for your teammate or someone else. And the 18-year-old is not the same as the 40-year-old. And if they have a high slope, it's not the same as not. And so we can fix some of these factors, or at least address them, or do a different surgery or an additional surgery for it. So just make sure that your surgeon's looking at all of these factors, because they're all critical. And knowing the mechanism, knowing this anatomy, helps you understand the forces. It highlights the anatomic and genetic risk. Some of this risk we can't fix you out of, being female. If you want to return to cutting and pivoting sports, these are the things that we can't, so we can only improve some of them. So we need to know all of them to be able to understand this. It also makes your surgery options understandable. We'll be able to talk now, if you've watched this, and understand why a simple ACL is not the right answer, or we need to do something slightly different. And then injury prevention. Okay, so this is really important with physical therapy after the surgery. It's not just about rehabbing the knee. It's about preventing this from happening again. Looking at your core, looking at your hamstrings, look how you land, look at your anatomy and landing mechanics. This is part of the whole picture of treating your ACL, because I don't want to see you back again for another one. So general overview, anatomy. Soon, next we'll get to actually tearing the ACL. I know I talk on about this stuff, but I think it's important, if you're going through this, to understand your problem, because again, ultimately, this is your body and what you need to be dealing with. So next we'll talk about ACL tear, associated injuries that come along with it. Thanks again for watching, and let me know if I can help in any way.